Welcome back to Community Medicine Part 2. So we'll be continuing with the epidemiology type further studies. As we were talking about in the last part of the video was case control and cohort. So let's talk a bit more with respect to case control and cohort, alright? So if you talk about details with respect to what are the specifications with respect to cohort study, remember it's going to be expensive. Why is it expensive? Because it's going to be a follow-up. You're going to be doing that study for years and years. Okay. What can be calculated? Incidence. Remember when we were talking about relative risk, population attributable risk and attributable risk, right? So incidence is all the new cases which are being found in the disease, and obviously in a follow-up cases you will be finding new things. Then you will have biases, which is attrition bias, which is also known as follow-up bias. We'll be talking about this later. Hawthorne bias. These are the two bias which is usually seen in cohort. Whenever you do a cohort study, you require an ethical clearance because you're going to experiment on something. Now, the most you have some things which is known as the Hills criteria. Okay, in the Hills criteria, the most important part in case of cohort is going to be temporal association or natural history of disease or cause precedes the effect. These three are the same thing. What they're trying to say is that for something to happen, there should be a risk factor before the disease. So that is what we are basically doing in cohort. We are having two risk factors, risk factor present and risk factor not, and then we will see whether the disease is present or not. So this is known as temporal association or natural history of disease or cause precedes effect. So this is, remember, Hill's criteria of association, in which temporal association is the most important. If you talk about case control, in case control, remember it is done for obviously what we are starting with diseases, right? So it is easy to do for rare diseases, and cohort will be done for easy to do for rare risk factors. In case control, you cannot find incidence. What do you do there? You do a cross product ratio, which is known as the odds ratio. What was the bias you saw in case product? That was your appreciation bias, which was seen in cross sectional. Very good. And in case control, what you were seeing? Recall bias. Very good. What was recall bias? Because those who were not affected by the disease, they will not remember exactly which exactly what how many people they met before or something like that. Example in the COVID case which we did. What was appreciation bias in cross sectional? It is the answer is changed based on the interviewer. So that was cross sectional. Remember, appreciation bias cross sectional. Recall bias is going to see in case control. In cohort, now you have Hawthorne bias and attrition bias. Okay. So similarly, whatever I just talked about, this is a table over here as well. Okay. Next. So what I was talking about was the Bradford Hill criteria. These are the Bradford Hill criteria. You can try to remember them because they have been asked a couple of times in the PYQs. So strength of association, consistency, specificity, temporality. Temporality is the most important one, remember, okay? Biological gradient, possibility, coherence, experimental evidence, and analogy. If you want to know the meaning of the definition, because a couple of the times they have given it in INICET as well. So over here, there is a definition of each of them. But remember over here, temporality, which is cause precedes the effect. So these are the very important and most important part. Okay. So remember, if they'll ask you what is the strongest association which will be there, the strongest association with respect to risk ratio. Let's talk about that. A strength of association. The strength of association is detected by. Now see, now association we told both things. Remember, odds ratio, yeah, relative risk ratio. If it is equal to 1, there is no association. If it is more than 1, then this is positive association. And if it is less than 1, it is negative association. Like anyway, okay. So that is the thing. Now, if they will ask you which is more superior with respect to odds ratio or relative risk ratio, you need to remember that it is going to be your relative risk, which is going to be much more important. Now, I'll give you two reasons why. Relative risk, first of all, is going to get you new cases. It is going to help you with help of incidence. Now, if you see, usually odds ratio is something which is used by the clinician because we have the disease. Now, we want to find out the risk factor. Okay. Attributable risk. Now, attributable risk, remember what I told you? What is the meaning of attributable risk? In layman way, it is that, for example, smoking we're talking about attributable risk of smoking in lung cancer. Attributable risk will tell you how much smoking is responsible for causing lung cancer, a single cause. Whereas population attributable risk is used for making healthcare plans, public health plans and stuff like that. Relative risk is the best. If they'll ask you if a question comes, the strength of association is best detected by relative risk. So remember that strength of association is best detected by relative risk. If they will ask you a question, if there are the relative risk ratio, what is the meaning of relative risk? Incidence of of disease in the exposed divided by incidence of disease in the non-exposed, correct? So relative risk, if they're asking is 0.85. What does it represent? Now, anytime a value which is getting closer to 1 or more than 1, it's giving you an idea that this risk factor is responsible for the disease. So what is the remaining part? That is 0.15. If you see 0.15 into 100, that is 15%. So what is this 15%? This 15% is indicating there is less risk of a certain disease. So over here, if you see that this is 0.85 and they're asking what does it represent with respect to MI for this question, the answer is going to be 15% less risk of MI. Okay, 15% less risk of MI because that is going to be the remaining amount. Similarly, if RR is 0.4, which means 40%, so what is the remaining part? That is 60%. So 60% of less risk in the exposed group. If the RR again is more than 1, that is going to be causative association or positive association. If you have a similar question in which the RR or the OR, you found out is going to be 8. So 8 is to 1. 8 is to 1, which means is with respect to this question in which the accident risk is much more in alcohol drivers than the accident in non-alcoholic. So over here, it is more than 1, which means definitely alcohol is found to be associated with accidents in case of RTAs. Okay. Whenever the RR is going to be 1 or more equal to 1, odd ratio is also equal to 1, which means there is no association. Please make sure you know that. If now you have a question, in study 1, RR was 0.5 and study 2 is RR is 2. Now find out what will be the plot. Okay. Over here, first what they're trying to say is we have one value which is below 1 and one value which is above 1. Okay. So now we know that our graph, if it is going to be something like this. So over here, first we need to know, okay, so how can you rule out over here is, you know that, okay, this is not going to happen, this is also not going to happen. Now you have B and C as option. How are you going to choose? Remember, over here, where in RR or OR, what is no association? 0 or 1? It is going to be 1. Because 0 still has a value, it is less than 1, which means it is negative association, which means it's a protective factor. Over here in RR and O1, which we told about, where there is no association, that is going to be 1. So that is why over here, your main horizontal line which will be there, it is going to represent with 1 and not 0. So your answer over here is going to be B. I hope you understood. Simple. Now let's go on with our next next topic, that is going to be evidence-based medicine. In simple, what is evidence-based medicine is that we are going to tally, for example, if you have something to diagnose, we're going to use multiple studies to confirm everything, and then we are going to proceed with our procedure, which means we're going to cross-check multiple times. The term, remember, it was coined by Sackett. It is giving the best patient care by utilizing the data of different types of studies so that we will have the best patient care. Multiple studies are used. Now you need to remember the hierarchy with respect to the studies which we have talked about so far. The strongest evidence comes from, for number 1, we'll talk about this later, meta-analysis. Okay. Now over here you have to remember the order of which study is superior than which. So if you go from bottom to top, first of all, expert opinion. Normal expert opinion, that is considered the weakest with respect to all the comparative studies. Then will be the case study, case series, ecological study, cross-sectional study, case control, cohort. Still here we have studied all of these. Remember, this is the hierarchy. One more time: expert, case study, case series, ecological, cross-sectional, then is the case control, then topmost will be is cohort. Now after this, which we are going to talk about is RCT, which is randomized control trial. After randomized control trial is going to be your systemic analysis, and the topmost position, which means the best, if you want to talk about the best study to get best result, that is going to be meta-analysis. You have to remember this order, because now what they in the further questions, what they're going to ask you is which data can we collect from the best study. For example, which of the following is the best study to compare exposure, effect, and outcome? Now, if you know the order, if you go top to bottom, from bottom to top, first will be your case series, then will be your over here cross-sectional studies, then will be your case control, and then will be your cohort. So the most superior over here is going to be your cohort. So your answer is going to be A. And then, now remember this: a drug is causing congenital anomalies. Which study will be the best to confirm the result? Now see, if you will just go with the fact which I told you, remember the hierarchy, you would obviously mark over here as RCT. Correct? But read the question one more time. They're asking is a drug is causing congenital anomaly. Now, even if we still haven't discussed about RCT, you know that this is a randomized control trial. Remember, RCT comes again experimental or interventional study. So tell me something, when you know a drug is going to cause congenital anomaly, will you still voluntarily give this drug to someone so that you know whether this is really causing it or not? No, it is ethically not right. So remember, ethics also comes to role. So please make sure you're seeing the question very carefully. Over here, a drug is causing congenital anomaly. So what we are going to do is, already who people have been affected, we will go there, who has this disease, and then we will go back and find out what were the risk factors, because this is ethically more moral. because they already have been unfortunately affected. So we will go back. So what I'm trying to say, who has a disease, and then we're going back. Very good. It is going to be case control. So your answer is going to be case control, because this is now ethical consideration. Over here there was a simple layman question, and you got to remember this by hierarchy. Over here you should not only aim by hierarchy. Over here you should apply some logic as well. Cool. Next we'll be talking about meta-analysis. Meta-analysis is also known as analysis of analysis. Step 1, what you're doing is you're going to collect all the data done on one topic. Step 1. Second is we're going to combine all the theoretical study of all of them to find out one solution. First we collected, okay, for example, we're talking about breast cancer. How many researchers are done with breast cancer? As much as I can find, I'll find. Then whatever was the final conclusion, I'm going to collect it all and make one thing. That is, these two steps together is known as systemic review. Only these two steps, remember, step 1 and step 2, which means first search all the topic and then make a theoretical result. Third step now is when you combine all the data of all the studies into one, which means analysis of analysis. When you're taking a double one, you got a theoretical framework, and then when you're adding again and you're finalizing, which means a double check. That is why meta-analysis is known as analysis of analysis. When you just analyze the first time, when you found out data and then you combine, that was just one thing, that is systemic review. But again, when you combine and get a final conclusion, that is known as meta-analysis. That is why you notice that meta-analysis was the topmost, then came systemic review. So remember, step 1, 2 and 3, combination of these 3 steps together is meta-analysis. Now, to represent the combined result of all the study in meta-analysis, we use 2 plots. One is going to be your forest plot, and the other one is going to be your funnel plot. Funnel plot is also used in something which is known as publication bias. What is this forest plot? In forest plots, first of all, you see this is the vertical line and the horizontal line. The horizontal line expresses the range of confidence interval. Confidence interval is the probability of the disease to happen. So over here now, whatever these black boxes are, these are basically saying is how much has been like the majority and how many times that this study has been occurred in the specific point. The larger the point, more precise, more number of studies are acting over there. So this is study 1, 2 and 3. When you want to combine these 3 studies together in the horizontal confidence interval, you represent it with the form of a diamond. That is a combination of all the 3 studies. Bigger the box, more precise the result, that you should know. This is your forest plot, sorry. Now funnel, because it looks like a funnel, ultra type of funnel. What is there is, the more you have it towards the center, the better it is. If you go away from this main point, then if you go left side, it's going to be negative association, which means it was a protective factor. And if it is going more towards the right, it is going to be a risk factor. We want an ideal situation in the middle around. That is the funnel plot. What you only have to remember in this thing is to just remember forest plot, funnel plot. Where do we use it? We use it in your meta-analysis. Remember, your funnel plot can also be used in publication bias, and your forest plot may, when you want to combine 3 studies in one, you use a diamond shape. That is it. Next, which of the following is not done in meta-analysis? We talked about searching of study. Yes, so searching of study is there. Then we did combining all the theoretical data. Till here, both of this is alone. If only this 2 was given, this is your systemic review. But then when we did analysis of analysis, these 3, A, C and D, these 3 is known as meta-analysis. So what is not done in meta-analysis? Very good. Randomization is not done in meta-analysis. Simple. Including in this similar question, if they ask you which one is done in systemic review. Systemic review में क्या क्या होता है? In systemic review, you will search the study and then you combine the theoretical result. Okay, these 2 are systemic review. So your answer over here is going to be C and D. If you add A, that is going to be meta-analysis. Okay. Now what is randomized control trial? Randomized control trial, for example, with let's take an example of a drug which is modafinil, which is usually trying to make you awake and so that you will be productive and something like that. See, you have 2 groups, group A, group B, 200 students. So for 100 students, what you're going to do, you're going to give actual modafinil, and for other 100 students, you'll just give a normal placebo. Okay, they don't know that it's actually a placebo. They'll be working on their own, and then people who are having modafinil, they also don't know. What we're going to do is we're going to follow up every day they're going to take it. We're going to follow up them for after 1 month. After 1 month, what we are going to do is we're going to collect our data, and then we are going to find out what data was there. So this is a randomized control trial because we're experimenting till here. So this is known as your randomized control trial, and this is known as your parallel RCT, in which one group we are giving a placebo, one group we are giving a disease, and then we are finding out later what happened. So that is your RCT. Now what we, after this what we do is, if we are going to wait for 3 months, if we are going to wash out the effect of the drug, and then now group A who had modafinil is then going to get placebo, and group B who had the placebo, now they will get the modafinil. So we're crossing, and now we're going to experiment, and then we're going to find the result. This is known as crossover RCT. When you're not crossing over, where placebo is given to one group and only the drug is given to another group, that is just known as parallel RCT. After a period of washout, then we are going to cross, and then A is going to get the placebo and B is going to get the drug. That is known as cross product. What is the advantage of cross product RCT? The advantage of cross product RCT is both the group will get the disease. Both the group will get the drug. The sample size will obviously increase. Every participant will act as both control and treatment. So for example, if there is a disease, and in a disease, you know that this is the treatment and that is given to A, and B is not getting the treatment. Basically, he also has a disease. So ethically, it is not right that we are just experimenting on him. So this ethical issue gets cleared by cross RCT. Now something like vaccines cannot be done by cross product, because cross product cannot be, you will never have a washout of vaccine, because still we cannot clear it out. For example, drugs can be metabolized by the liver, right? But vaccines cannot. So that's why in case of vaccine study, you can only use parallel RCT and not cross product RCT. Okay. Then RCT does not have selection bias. Now we'll talk about selection bias, observer bias, volunteer bias later on, but just remember, RCT does not have selection bias. The best way to remove selection bias is going to be randomization. In short, selection bias is, it has volunteer bias and Parkinsonian bias and all. It is based on our perspective that, okay, if someone is coughing, I think this guy smokes, like that. It is not correct. Cough can be multiple reasons, but still that is my selection bias, and this can be removed by randomization, randomly call from a group of people, correct? If you talk about now types of biases and stuff like that, we have another way to prevent this all biases and all, that is known as blinding. Blinding can be of 3 types. It is going to be single, double, triple. Single means the patient is blind. The patient does not know what he is having. Double is when the patient and the researcher both are blind. They don't know who is having the placebo or like that. Triple is even when the analyzer is also blind. The best and the toughest one to do is going to be obviously triple. The most commonly done is going to be your double. Okay, so this you need to know with respect to bias. What is researcher bias, observer bias, or interviewer bias? As we were already giving an example of the cough for a patient. For example, in our volunteers, we have volunteers to test what are the causes and effects of smoking. Now, I have seen already 10-20 people in the group who are smoking. Already now, I have decided based on what my perspective is, that how obviously they're smoking because they're coughing because they have smoked. So this is my bias, that now see, coughing can be due to multiple reasons. Maybe they have an URTI, maybe they have some infection, or maybe they're just randomly coughing because of a season. But now, because I am now biased toward that, yes, they're coughing already because most probably they have smoked. This is known as research bias. Already I am decided because of some side effects or something like this, that these are my these are the people who I want to test on, which can give a false result. Correct? So this is known as researcher bias, observer bias, or interviewer bias. Researchers forcefully proves his or her idea to correct by taking the idea from 2 differential groups. Okay. Next, let's talk about confounder. Now, I want you guys to remember confounder as see, for example, there is a guy and there is a girl. They both are going to be in relation, and there will be a middle person who is the best friend for both. Remember, confounder is the best friend who is related to both the boyfriend and the girlfriend, but there is no relation. If the best friend is not there, still they both are going to get in relation. What I'm trying to say is that confounder is something which is related to both. If you will see, it is related to the exposure as well as to the outcome, but it does not come in the casual pathway. Okay, the causal pathway, what I'm trying to say is, like in this example, is going to be relationship. If this best friend is there or not there, it doesn't matter. They both are going to get in relation. This best friend is correlated to both. There, sometimes he's a more best friend to the male, or sometimes he's more best friend to female. So this is what is confounder. It is related to both exposure and outcome. It is unequally distributed to both the groups. It does not come part in the causal pathway. Okay, so I hope you understood it with this example. Then you have something which is the effect modifier. Effect modifier is only related to the outcome. So over here, our exposure was the guy. The outcome was the girl getting accepted. Common friend was the best friend for both sides. And the friend of the girl's best friend, so that girl is only related to the outcome. So an effect modifier is only something which is related to the outcome. But a confounder, C for confounder, C for common friend, they are related to both. They are mixed. Sometimes he is best friend for the exposure, sometimes he is more to the outcome. But it does not, this best friend presence or not present does not matter. The causal pathway is going to happen. Let us take examples of this and you will understand more. For example, you have someone who is consuming alcohol. This person can get an increased risk of oral cavity cancer, correct? Now, you have two things which this person also does. One is smoking and one is tobacco chewing. Now, both of these also cause cancer, correct? Both of them are also going to cause oral cavity cancer. Now, which can be related with respect to a confounder? What was confounder? Confounder is related to both alcohol and oral cavity. Now, smoking is a confounder over here. Why? Because during alcohol, you must be seeing people, they also smoke. And smoking also causes oral cancer. So these two things are done together. Now, who has this tobacco chewing or gutka chabata hai? Have you ever seen a person who is consuming alcohol and also eating tobacco at the same time? No. But tobacco and alcohol, tobacco chewing and gutka can also cause oral cancer. Yes. So this is only related to the outcome, while smoking is related to both oral cavity cancer as well as alcohol. So in this case, smoking is the confounder and gutka or tobacco chewing is going to be your effect modifier. Next example, smoking can cause cough, correct? Allergy also can cause cough, correct? And TB also causes cough. Now, what you can find out over here is that smoking and allergy are not associated. Smoking does not cause allergy, that is there. But smoking causes immunocompromised, it immunocompromises the patient, which can cause TB, and TB can thereby affect, the side effect is going to be cough. So this is now correlated. Whenever there is correlation between the two, that is going to be confounder. While when there is only associated with the outcome, that is going to be your effect modifier. So allergy over here is going to be effect modifier and TB over here is going to be confounder. Next question. Coffee drinking causes pancreatitis. Alcohol also causes pancreatitis. Smoking also can cause pancreatitis. Now, have you seen anyone who's drinking coffee and who's also drinking alcohol also at the same time? No. Maybe it will be a different brand, but that's not the question over here. The question is, have you, like, whether people do it together? Usually they do not consume it together like that, correct? But you have seen people smoking and drinking coffee at the same time, which means smoking also causes pancreatitis. Smoking also can be done with coffee drinking. That is why smoking over here is going to be the confounder. While alcohol over here can cause pancreatitis, but it is not associated with coffee. So that's why this is the effect modifier. So simply, effect modifier is something which is only associated with the outcome, while confounder is something which is associated both with the effect and the outcome. Remember, confounder will not change the path of the causal pathway. Coffee drinking will cause pancreatitis even if there is smoking or not. I hope you understood this. Next, matching. Now, if they'll ask you, see, this question was over here. Remember, without confounder or effect modifier, there can be an outcome. So remember, that's why they do not come in the causal pathway. Boyfriend is going to propose to the girl even if there is the common friend, even if it's there, he's not there, even if that girl's best friend is there or not there. Simple and easy basha. Okay? Next, remember, matching removes known confounder, while randomization can remove both known as well as unknown confounder. These are some MCQs, directly one-liners, just mug it up. Okay? Next, whenever you talk about any vaccine, there is always efficacy, right? 81%, like, Pfizer had 96 something, then if you, light came, wow. So if you talk about 81% and light went, wow. So 81% efficacy, which means is like for some people, they will have, for Pfizer had 96% and some, then other ones like Covishield and all, they had 80%. What does this mean? They're basically trying to say is, whenever, for example, if a vaccine has 81%, they're saying that if a patient took two co-vaccines, within 6 weeks, they have 81% chance less to get hospitalized as compared to someone who is not vaccinated. So if there is a question with respect to vaccine and they say, what is the meaning of efficacy in this case? Efficacy basically means that if they have taken the complete schedule of the dose which is recommended for the vaccine, that many times, if it is 50%, which means it is 50% chances less to get hospitalized as compared to someone who has not taken a vaccine. Okay. What is the meaning now of these 2 points? These are very important. They have been asked multiple times. Remember one mnemonic, VAC. Okay. Validity, accuracy, and correct results. VAC. Validity, accuracy is how many times have you got the correct result. For example, the correct result is 10. How many times have I got 10? 10, 10, 10, 10, or around 10, 9.8, 9.9, 10.1, 10.2. That is your validity, accuracy. So what do you remember? VAC. Validity, accuracy, and that is correct result. Next you have reliability or precision. Remember this by RRRP. Reliability, also known as repeatability, also known as reproducibility, also known as precision. Now what is this RRP means? How many times have you got this correct number, the same number again and again and again and again. For example, I want to score 10, but again and again my result is coming 7, 7, 7, 7, 7. So this example, if 10 and 7, if you talk about validity and accuracy, this is having poor validity accuracy, but this is having a high reproducibility, reliability, repercussion, and precision and all, because they are repeating again and again and again the same number. So remember, what for this example, if the answer is you want 10, but you're getting 7, 7, 7 more, it is going to be low VA, but it's going to be more RRP. I hope you understood this. Let's take an example over here. Remember, both the validity and reliability will increase with respect to sample size. Sample size, the more the sample size, always it is better. Okay, Z is the name. Now for this example, which one amongst the following is more precise and valid? You're having A, B, and C. Now with this graph, you can find out that C, not only C has the majority, also the chances of thing to happen again and again at the same site is more. So what you're trying to say is C has more like validity and accuracy, and it has also more RRP. It is repeating also at the same time, and the answer also, the value also you're getting correct. Okay. Next question. If you want to get a target of 10, but you're getting 9.6, 9.8, 9, 10.2, 10.4. Now, obviously, you're not the reliability or precision, the repeatability or reproducibility is not coming the exact number, but your value is 10 and you're getting close to your desired result multiple times. So this is high validity. Whenever you're getting the answer closer to what you want, that means validity or accuracy. Whenever you're repeating the same thing again, irrespective of what you want, that is high RRRP. Okay. Next, same question. Control solution. The control study to check for new hemoglobin measuring device was giving you this value for 5 days. 7, 7.1, 7, 7, 7. But you wanted a goal of 10. So you are not reaching your goal. You are not close to your goal. So that's why there will be a low VA. Low VA will be there. But you're having the result which is getting is regularly again happening same with the same number. So that's why it is going to be low VA and high RRRP. I hope you understood. Next, let's talk about bias. We have already talked about confounder. Again, what was confounder? The common best friend related to both the effect and the outcome, and it does not cause any result in the causal pathway. Next, we'll be having your selection bias. Selection bias can be of two types. One is going to be your volunteer bias, and then is going to be your Parkinsonian bias. Then you will be having measurement bias. Recall bias is seen in case control. Very good. Researcher bias. Then attrition bias. Where was seen it is in cohort. Hawthorne, again seen in cohort. Appreciation bias is seen in cross-sectional. Very good. And Neyman bias. We'll talk about it where it is seen. Okay. Now, normally errors can be of two types. One is your randomized error and then your systemic error. Whenever you're having a randomized error, it is most probably a sampling error. And then whenever you're having a systemic error, it is a bias. And now bias case we have already talked about. These are errors. Okay. Let's talk about volunteer bias. Now, volunteer bias, as I already told you, is that it is based on my selection. For example, what they actually did in COVID-19 vaccine was they had two groups. One was the healthy hospital doctor going group, and the other group was village poor people who were already immunocompromised. Now, obviously, when they took group A and group B, and with vaccine 1 and vaccine 2, group A, who were the doctors who were given vaccine 1, obviously they were more strong, they had a much more stronger immunity, which showed a false positivity that the vaccine A is much more stronger. On the other hand, the people who were already very low in immunity, how much could a vaccine help? So that was volunteer bias. We took a wrong group and the comparison was wrong. That is why matching is very importantly required. Remember, we talked about matching in cross-sectional or in case control type studies, correct? Next, we are having Parkinsonian bias or hospital rate admission bias. What is Parkinsonian bias or hospital rate admission bias? Example, I am a psychiatrist. In my OPD, out of every 10 patients, I am going to see 8 patients who are depressed. And I am seeing this every day, 6 hours, 7 hours, 8 hours a day, every day. Now, what I think is, because these many patients are coming to me who are mostly depressed, I am thinking the whole world is depressed. But why is this a bias? Because right now I am a psychiatrist. Obviously, depression people are going to come here. If I go to the general population or if I go to the medicine department, no, you will not find too many psychiatrists. You will see there are other all diseases, and depression on the other hand is not that much common. So this is a bias because of my specialization, that I am thinking whenever I go out and I will talk to the another specialization, I'm like, yeah, in the world there are so many depressed people. But that is wrong, because of my specialization, I am only getting them. And then I am thinking now that everyone in the world is depressed. So this is known as Parkinsonian or hospital-based admission bias. Patient coming to the hospital or admitted to the hospital, depending on the specialty present in the hospital, it does not represent the actual prevalence of the disease. Makes sense? I hope you understood. Then is attrition bias or loss to follow-up. Now what happens in attrition bias, just remember, attrition bias is also known as loss to follow-up, in which, for example, two groups are group A, group B. People can get pancreatitis with the help of alcohol. People getting pancreatitis without some other drink. Now person who is having some other drink, now that guy all of a sudden left the study. And this person is continuing who is having alcohol. And then what I found out was that those people who were drinking something else, they did not get pancreatitis. And this person who was drinking alcohol got pancreatitis. Now this study is not correct. Why? Because the other group was already left. What if this group also, which we lost to follow-up, could cause pancreatitis, correct? What they were drinking. So this is known as your attrition bias, also known as loss to follow-up. Then is Hawthorne bias, also known as attention bias. Now Hawthorne bias or attention bias is usually seen in cohort study. Why? Because, for example, if I'm going to observe you, I'm going to check, okay, I'm giving you any drug which is going to increase your mental strength. Every day I'm going to now observe you, you're studying and I'm just sitting here and staring you like this. Now obviously your behavior is going to change. कि यार कोई पागल बंदा मेरे को ऐसे घूर रहा है. So obviously some behaviors, some starting now, and I will be also forced to, okay, he's seeing me, so I'll have to start studying. If he was not there, maybe I would not study. So you're understanding what I'm trying to say. This Hawthorne bias is because of the how the behavior of the participant is going to change under observation. This is Hawthorne. Appreciation bias is because you are right now freaked out. Key example, like how I give you the example of sex. If I ask you all of a sudden, how many times have you had sex? Even though you will answer, you know your answer and you might answer, but just because of the crowd and just because of the person is there, his attitude, you will change your answer. That is your appreciation bias, which is seen in cross section. So what is Neyman bias? Neyman bias is usually seen in cases in which there will be so high mortality. Let's take an example of Ebola virus. Now when there is an outbreak of Ebola, there will be so many cases, but these people die very fast. That you will see there are so many cases, which means when there are new cases, what is this called? This is known as incidence. But when you see people are dying, so many people are dying, that is why the prevalence will be reduced. Because prevalence is a combination of total number of old disease and the new disease, which will be reduced. So whenever you're going to have high incidence, which is HI, high incidence and low prevalence, that is known as Neyman bias. Example can be like influenza or Ebola virus. I hope you understood this. Okay? Prevalence is total number of new cases and old cases. There is a formula for prevalence as well. That is going to be incidence multiplied by the duration of disease. Now, if you have a question over here, a new drug does not cure the disease but prevents the death. A new drug does not cure the disease. So the patient has the disease, but he is not dying also. What will be the effect of prevalence and incidence? Obviously, the patient is not dying. So the prevalence is going to increase. Is there any correlation of this drug to prevent the disease? No. So that is why the incidence is going to be the same. So prevalence is going to increase and incidence is going to remain the same. I hope you understood. Next question. If a new drug cures the disease quickly, then what will be the prevalence and incidence? It is curing the drug quickly. So that's why the prevalence is now going to decrease. But is it preventing the disease? No. That is why the incidence is going to remain the same and the prevalence is going to decrease. I hope you understood this topic, and I'm so sorry for the light fluctuating on and off, but this was mostly with topics which were related to the PYQs which were recently coming. I hope you understood. Let us summarize this finally. Hospital compared, whenever you're comparing a data which is hospitally compared with population data, this is known as ecological study. And can you tell me what is ecological study, also known as another PYQ? Please comment below so that I can know that you're waiting till the end for this video. Next, question asked and at present situation, whenever you ask a question in a study, that is going to be known as cross-sectional study. Cross-sectional study is also known as prevalence study, and it is also known as, please comment that also below because it is a very important PYQ. Case control, whatever you start in case control, you start with a disease present and start and who has disease present, who has does not have disease. What is the bias? It is going to be recall bias. It is going to be recall bias. In cohort study, you start with the risk factor, and if there is a patient who has risk factor and who does not have a risk factor, what are the biases which you find? You find Hawthorne bias, attrition bias and all. I hope you understood this. Next, we'll be talking about waste programs and the programs which are say waste, how do you dispose waste, and the multiple other programs which are there in India. If you have any other doubt, feel free to text me on Telegram. I'll be more happy to help. Share this video to people who have difficulties in PSM, and if you have any other more doubts, again, I'm always there for you. So take care. See you guys in the next video. Bye-bye.